to see every one of you. And today we want to talk about some kind of problems with the diagnosis of joint swelling other than juvenile idiopathic arthritis. So we choose this topic because sometimes it's a dilemma to diagnose is this juvenile idiopathic arthritis, or maybe it's another diagnosis. So I start my presentation. We plan to present two cases, and I start the first one. And let me share my screen. Okay. 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 Can you see my screen?
Yes.
Yes.
Okay. Okay. The first case is some kind of differential diagnosis between hemarthrosis or JIA. Okay, our case was a boy born in 2011. First admission in our center was in 2016 when he was 5 years old. Chief complaint of his admission was swelling of left knee from a couple days ago and multiple bruising on his body at the time of admission. He also has some kind of complaint in his past medical history. He had multiple bruising on his body from the age of 6 months and multiple minor joint swelling and also epistaxis. In the year 2012, complete workup for bleeding tendency disorders was done, and all of them were normal. Here, some of them, for example, PTT was 38, which was normal. Factor 13 was normal. Forebrain antigen was normal. Forebrain activity was normal. Fibrinogen was normal, and all of his test about bleeding tendency disorder was normal.
Dr. Sadeghi, we seem to have lost you.
Sorry, but we cannot hear you.
I wonder whether he's lost his connection, because I'm not getting screen sharing anymore either. I don't know if anybody else is.
Me neither.
We'll just wait for him to hopefully re-establish his connection.
Yes, I think it's a
نیلوفر که خانم بالاخنی
خانم چیز خانم ببین کمک بده.
We have your voice, Dr. Sadeghi.
Hello again. Hello again. Sorry for the interruption. Suddenly everything crashed here, and this is some kind of problem of virtual meeting. Okay, I continue my presentation from here. Okay, the patient received some doses of vitamin K and fresh frozen plasma, but this treatment was discontinued after the normal results of lab studies. In July 2020, he came to our patient clinic with decreased of right knee range of motion and painful movements. In physical exam, he had mild effusion and erythema of this joint. Planned lab study and ultrasonography whole body scan. The results were sono minimal effusion of right knee, bone scan inflammatory process in both shoulders, right elbow, right wrist, right knee. Lab study was normal. Rule out of other conditions, unknown, and RF was negative. Plan naproxen plus methotrexate and folic acid. He again visited in October 2020. He had swelling of left elbow and right ankle. Planned treatment continued and lab study to consider the orthopedic etiologies. To other etiologists, at this time, WBC was 7,100, hemoglobin was 20, platelet was 244,000, ESR was 3, CRP was negative. Again, PT and PTT was normal. INR was 1.1. He also visited he was visited again in March 2021, but he had no good results of therapy. Naproxen discontinued and low-dose prednisolone began. Again, another visit in May 2021, continuous involvement of left elbow, plan increase of methotrexate dose. Again, another visit in August 2021, return of right knee tenderness and decreased range of motion, plan MRI and increase of prednisolone dose. Here you can see some images of the MRI, which is done.
May I speak?
Yes, let me just stop the view. At first, I must say, I must thank other colleagues from other fields, which I invited to our meeting, and I thank all of them, especially the radiologic field and orthopedic field. Let me introduce one of my scientific colleague, Dr. Zamani, who is a radiologist of our center, and I asked her to talk about the images of the MRI, who could lead us to the diagnosis of this difficult patient. Okay, Dr. Zamani, podium is yours. You can speak every time you want. Okay.
Okay. Hello, dear eminent professors. I'm Fatima Zamani. In sagittal fat suffers T1 with IV contrast MRI, you can see pre-articular soft tissue enhancement in this sequence that Dr. Sadeghi showed to you. Okay, you can scroll. You see soft tissue hyperintensity in suprapatellar pouch in medial part that shows pre-articular soft tissue enhancement and inflammation. That could be synovial enhancement or muscular enhancement that don't completely see in this MRI. And you see multiple reactive lymph nodes in the posterior of knee, in knee joint. It's T1 PATSAT axial with IV contrast, and you see the same as the sagittal hyperintensity and enhancement in periarticular soft tissue in medial side of suprapatellar pouch. You don't see any joint effusion, any fracture or abnormal bone marrow intensity. Do you have the coronal sequence? And can you show it?
Sorry, Dr.
Okay,
Zamani, we have just these views of the MRI here.
Okay, it's
I-
enough. You don't have any problem in knee, but as a joint effusion or problem in ligament or meniscus. All of them have normal appearance, and you have only prearticular soft tissue enhancement in medial side and multiple reactive lymph nodes. Synovium maybe any abnormality in synovium too.
Okay, thank you, Dr. Zamani. As you can see, for this patient with history of hemarthrosis and now with the history of some kind of joint inflammation in physical examination, we don't have a very definite diagnosis for this patient. Of course, he doesn't have good response to our treatment, and now it's kind of dilemma for us how to diagnose this patient other than JIA. For example, thinking about another diagnosis could completely discussed about all the problems of the patient. Now, we present this patient to talk about in this meeting because we want to have your idea, Dr. Leahy, and your colleagues in Southampton Children's Hospital. Do you have any idea about this patient? And we can talk about it and discuss about it, and then talk about the another patient that we have.
So can I just ask, you talked about other joint involvement.
Yes, yes.
Did you say that there was shoulders and something else? I've forgotten which joints you said.
Elbow. We have.
Elbow.
He also had some kind of involvement of the elbow, wrist, and we don't have any definite explanation for this kind of involvement. At first, yes.
Sorry, the ultrasound scans of elbow, wrist, do they show any inflammatory changes?
We did whole body scans, and it shows that there's some kind of inflammation and some kind of involvement in this area too.
I was just wondering whether ultrasound would be helpful to get a bit more detail on that, and it's also kind of quick and easy. I mean, do these joints feel hot, and are they obviously swollen?
You know, the problem with this patient was that in every visit he had one joint involvement. For example, in first visit he had right knee, and the another visit he had some kind of right elbow, and then right wrist, and then shoulder. He doesn't have this kind of involvement at one visit. We could only show this kind of involvement in whole body bone scan, that there is multiple involvement, multiple joint involvement. And now we have to track every joint in every visit. You know, this is some kind of problem, because when you do ultrasonography of for example, right knee, then in another visit you have another involvement in another joint.
Yeah.
So this is our problem, and
It's transient, kind of transient inflammation and moving around. It's a bit like the sort of palindromic
yes,
arthritis, isn't it?
yes, and also no good response to our treatment, even for JIA. We examined NSAIDs, for example, non-steroid anti-inflammatory drugs, and also corticosteroid, but none of them could treat the patient. So now we have problem with this patient. Maybe this is some kind of suggestion of our radiologists that we should try the MRI again, and with better view, maybe we could establish a good diagnosis for this patient.
Because the lack of response to corticosteroids and the absence of effusions as well, it doesn't feel like this is a, primarily inflammatory joint disease, does it? Because you really would expect some response to steroids. I mean, did he had good doses over a sort of reasonable period of time?
We used just low doses of the corticosteroid, between 5 and 7.5 milligram per day. We use these doses, we called it low dose prednisolone, not high, not medium dose or high doses. But we don't have any good explanation for the history of the hemarthrosis. We couldn't find any reason for this kind of history of hemarthrosis. Now, I have to say that we have problem for the making a definite diagnosis for this patient. So any other idea? If you have any other idea, could help us even after the meeting.
I will think about it, and I'll talk to our hematologists as well. But I agree with your colleagues that it doesn't feel primarily like a rheumatological, a primary inflammatory joint disease, and I wonder whether it is more of some bizarre hematological thing. So I'll talk to our hematologists as well and talk to my colleagues about it. It's a very strange case, isn't it?
Yes. And I sent you the slides for you for having good information about the patients. Yes,
yeah,
and thank
that would be really helpful.
Much. Thank you so much. So let's move on the other presentation, which is presented by one of my colleagues and one of our fellows, one of our good fellows in our center, Dr. Nasim Movahedi. I stop sharing my screen and she can start her presentation. Okay, Dr. Movahedi, podium is yours and you can start.
In the name of God. Hello and good afternoon to everyone. Do you hear me, Dr. Sadiqi?
We hear you.
Thank you. The case that I will present today is about a 10-year-old boy who presented to us with a chronic knee swelling. His chief complaint was a right knee swelling, which was started with an incidence onset from 4 months before presenting to us after a mild trauma. The swelling was restricted to the mentioned joint and there was no complaint of pain, decreased range of motion, or swelling for other joints. The patient was from a village in the west of Iran and had a positive history of direct contact with domestic milk products, but there were no complaints of systemic symptoms such as fever, chills, night sweats, decreased appetite, lumbar pain, nor skin rashes. Initial evaluation in his province led to obtaining an MRI of that knee, and the possibility of malignant bone lesions was discussed with the parents. So they came to Tehran for more evaluation. Our patient was visited with an orthopedic surgeon in an outpatient clinic in Tehran, and synovial fluid aspiration was performed. The results of the synovial fluid analysis consist of white BC count of 13,000. It had many RBC and the color was reddish. The parents said that the swelling disappeared with aspiration completely, but had reemerged rapidly the day after. He was visited in our outpatient clinic and then hospitalized in Children's Medical Center in Tehran for further evaluation. The patient had no other remarkable medical, surgical, or familial history and did not use any drugs. On admission to our center, his vital sign was stable. He had blood pressure of 100 systolic and 16 diastolic, pulse rate of 98, respiratory rate of 15, temperature of 36.5, and saturation was 97% in room air. The patients did not seem to be ill nor cachectic. No signs of any skin lesions were evident. Heart was normal, lungs were normal. There was no lymphadenopathy, and abdomen also was normal with no hepatosplenomegaly. On examination of the right knee, the swelling was not limited to the joint space and was extended to the upper parts of the thigh. This joint was not tender nor warm. Flexion of the right knee was limited, but other range of motions were normal. Other joints were normal. The patient had normal muscle tone and force. In this image, you see the lower limbs of this patient. Here, you can see the swelling, which is extended to the distal parts of the thigh. We performed some laboratory tests for these patients. CBC was first performed, which consists of white BC counts of 4,360. Neutrophil count was 39%, lymphocyte of 47%, eosinophil of 2.9%, hemoglobin level was 11.7, hematocrit of 33.5, MCV of 79, platelet count of 195,000, RBC count of near 4 million, ESR of 17, CRP2, INR 1.11, PT of 14.8, PTT of 32. Uric acid in first test was around 5, which was the upper limit of the normal range of our laboratory. So we performed a second one, which revealed to be 4.4. LDH level was 382. About rheumatologic markers, we performed some tests. Fluorescent ANA was negative, anti-CCP was negative, RF was negative, anti-double-stranded DNA was negative. Complement levels, including C3, C4, and CH50 was normal. PPT was 7 millimeter, and evaluation for brucellosis, including right 2ME and Combs right, was negative. So then we performed again a synovial fluid tap and analyzed it. On insertion of needle, we see that the fluid coming into the tube was completely bloody, exactly fresh blood. About 7 millimeter of that fluid were sent for analysis. It was red and turbid. RBC count of 480,000. white BC count of 900. It consists of 35% of neutrophils, 65% of lymphocytes. Glucose level was 91 milligram per deciliter, and protein level of 3.5 gram per deciliter. LDH level was 379, ADA level was 0.4. Direct smear for any microorganism was negative, and also culture was negative. Then we performed some imagings, including plain radiograph of that knee and MRI with gadolinium contrast enhancement to evaluate this knee further. Now I ask my dear professor, Dr. Zamani, to explain more for us about his image. Dr. Zamani, if you have my voice, we are glad to see you here. Yes,
Yes,
thank
I'm
you.
here.
And here to hear your nice explanation for this image.
You see AP knee X-ray, and as you see in yellow arrow, show to you soft tissue swelling and soft tissue mass in medial side of femur, and also you see diffuse periarticular osteopenia that could be due to disusement. Or not involvement of bone or bony erosion in this X-ray you see. Okay, you can show the MRI.
Thank you.
At the first figure you see, it's a T-bone facet that you see joint effusion is hyperintense to fluid. Yes, it's hyperintense to fluid, and it may show that you have a hemorrhage in the knee. Can you go to previous one? Thank you. In second figure, it's a axial T2. You say it show moderate to severe joint effusion with a fluid level that shows you have a hemorrhage and hematocrit level in the joint space, and you have a low signal fraud-like component in the medial part that it's show synovial thickening. Okay, you can go to the next slide. It's in sagittal T2. You see also fluid level and multiloculated moderate to severe effusion that has decreased signal along surface and septa of effusion. And in second sagittal T2, it shows yellow arrow the septa, and in yeah, it's a hematocrit level. Okay, you show, and in the second one, you see the decreased signal along surface and septa that shows the hemosiderin deposition and multiple front-like foci of low signal in articular joint. That is hypertrophy and villus and nodular projection of synovium. Can you go to the next one? Okay, it's a T-bone facet in sagittal plane with IV contrast that shows the synovial projection and fraud-like projection in joint space that have enhancement after IV contrast, and you have signal void deposits in the superior joint space in fluid, and also posterior to patella that shows the hemosiderin deposition, and it means it show to you PVNL in MRI.
Thank you very much, Dr. Zamani. So Based on our results in laboratory tests and imagings that were obtained, we concluded that to perform an orthopedic consult with our pediatric orthopedic surgeons in Children's Medical Center. They visited the patient and they recommended to perform a surgery for the patient. So he underwent a surgery, and radical resection of the mass and total synovectomy were performed for him. And now I ask our dear professor, Dr. Panjabi, who is one of our best pediatric orthopedic surgeons in Tehran, to explain more for us about the operation that were done on his knee. Dr. Panjabi, do you hear me?
Yes, of course.
Thank you very much. We are glad to have you here.
Me too. As a matter of fact, we did the surgery through a standard medial parapatellar approach, anterior one. And as you can see at the first figure on the left, there is a very prominent synovial hypertrophy after just cutting through the extensor mechanism and the retinaculum of the knee. We had a lot of serosyngenous effusion after going to the knee. We don't have any figure of the synovium right here, but as a matter of fact, it was very thick, and we had lots of nodules on its surface. And based on our MRI findings, we knew that it's a case of pigmented villonodular synovitis, and we decided just to resect as much as possible the whole synovium of the knee. To be honest, we were not very happy with the procedure because when you approach the knee from the anterior, you can't do a total synovectomy by this approach. And that's why we recommended to have maybe another modalities such as radiation therapy to prevent the recurrence of the tumor in future.
Thank you, Dr. Panjabi.
You're welcome.
We sent the samples for histopathology examination, which revealed multiple pieces of brown tissue measuring 9 in 5 in 3 centimeter. Sections showed diffuse sheets of cells with infiltration borders of hyperplastic synovium with papillary projection composed of foamy histiocytes and hemosiderin-laden macrophages. So the diagnosis was compatible with pigmented villonodular synovitis. Thank you very much for your nice attention.
Can I just ask a question of your orthopedic colleague? Do you have any idea how often these do recur? And is it quite dependent on how much of it you are able to access and remove, do you think?
Yes, exactly. As you know, we have two types of involvements with pigmented villonodular synovitis in joints. One of them is a localized form, and the best treatment is just a marginal resection of the whole tumor. But in those cases, which are diffuse type pigmented villonodular synovitis, you have to be careful to resect the tumor as much as possible. And as I explained before, when you approach the knee from just standard medial anterior palpatellar approach, you are not able to resect all the tumor. And I think the most significant factor determining the future recurrence of the tumor is your resection. And that's why we recommended our colleague in rheumatologic department to use probably radiotherapy to decrease the recurrence rate in the future.
Thank you.
You're welcome.
It's like a wait now for how many Europe Nigeria. They're going to know, but it will be good for me. You know, I have already joined that European Pediatrics Orthopedics with, you know, I'm more waiting for me to, I will benefit from here, but the rest I don't know, because I have certificates for that one.
Sorry,
Hello.
sorry, we couldn't hear you clearly.
To see the name now.
Hi, dear colleagues. Do you have my voice?
Yes, Dr. Astari.
Hi.
Continue.
Yes, I would be grateful to participate in this meeting again, and I would be hopeful to continue this meeting because it's beneficial for us. About the radiation therapy in PVNS or pigmented villonodular synovitis, or the other name of this tenosynovial giant cell tumor. The treatment approach is depends on something. For example, the availability of treatment and the characteristic of the symptom of the patient, because we have two forms, as we know. We have two forms of PVNS, the diffuse form and the localized form. The localized form is surgery is beneficial for this because we have lower rate of relapses, about 10%. But as Dr. Panjabi said, we have relapse rate in surgical in diffuse form, and we should cost benefit the treatment approach. In this patient, the diffuse form, the treatment, further surgery again and again have some complication. We have some long-term complications such as joint stiffness, such as joint replacement, and even the amputation of this extremity, involved extremities. And now, because of the physiopathology of these patients, that they have the translocation of some cells on the synovial that lining the articular, that this translocation stimulating factor 1 receptor. And more the treatment, the medical treatment or the systemic treatment approved for PVNS that inhibit for inhibition of this receptor, because they say that the receptor, when we have this activated these receptors, its requirement of macrophages, and requirement of macrophages leads to proliferation of these cells. And the inhibition of this, the approved treatment for inhibition of this in some letter are more support than radiation in patient. The name of although we don't have this medication in our country, but the name is pexidartinib. That is FDA approved for treatment of this patient. They say that radiation therapy, especially in lower age groups, for example, this patient, we are the pediatric patients, have some long-term complications such as joint stiffness, such as darkness, such as dysfunction of the articulars, such as second-degree malignancy or sarcoma in this patient, and they support the systemic prescription for this patient. But the systemic prescription, such as this drug, have the dark complication, hepatotoxicity, that is the non-compliance of the patient to this drug. Also, other anti-TNF patients have good responses, but we have done enough evidence base for this treatment. We have when we face with the articular that have a dough texture, not liquid, but in acute painful features. We think about it. Firstly, we think about it. Maybe it's not the simple oligoarticular JIA. We use the paraclinic, such as MRI and the others. But in pathology, maybe we have the similar pathology in PVNS, also in synovial sarcoma, in epithelioid sarcoma, or in rhabdomyosarcoma. And the multinucleated gyre scent only can help us to diagnosis, but unfortunately about 10% of patients don't have this. And they say that MRI modality that can help us in different diagnoses of this patient. Maybe different diagnoses of this patient are somehow are very difficult to, in this patient. About the first patient, I think the first patient have, I think Dr. Sadeghi have bruising and ecchymosis that, yes, dear Dr. Omar, I think, if I say it correct, about the platelet function, interesting factor, extrinsic factors, we should think about this. Maybe it's not a true arthritis, it's only the periarticular, as Dr. Zamani said, it's a periarticular inflammation that we should notice about this. And the lymph node that is, I think there was a posterior aspect of the knee in MRI. I think the infection, the reactive arthritis of infection may be considered, should be considered, for example, borreliosis or the others. Thank you very much. If you have any question, I would be grateful to answer.
Sorry, could I ask a question? I know here in Southampton, we are completely obsessed with ultrasound, so we'll often ask ultrasound related questions, but the PVNS before it was picked up on the MRI, did the child have an ultrasound? Because the appearances, sorry, the appearances are quite different on ultrasound in PVNS than in JIA.
Yes.
So would they routinely have ultrasound before proceeding to MRI, or I just wondered whether the kid had ultrasound before anyone put a needle in the first time.
Yes, I think the dough texture, not liquid texture, and inacute and painfulness of this article, because when we have the monoarticular that knee involvement, we have we may or more we don't have any pain in exactly in knee. Now in wrist or hip, in knee we have when we have the dough texture and painful arthritis, we should think about the other things in the first phases of this. It's my opinion, I think. Yes.
Yeah.
You know, Alice, the second patient came to Tehran, he did MRI before coming to Tehran. And when we visited the patient, we saw the MRI, and I must say, at first we think that okay, this is a JIA. Let's treat it, and as you said, put a needle and do aspiration, and then injection of the corticosteroid to the knee. But when we did aspiration, we saw that the sample is bloody and completely bloody, and this was surprise for us that this is not a simple JIA because it was true blood through aspiration. And then we decided not to inject corticosteroid to that joint and do more evaluation about the patient, because it was not similar to the other patients that we treated before. So we decided to repeat the MRI because the first MRI didn't have good images. And here we are in our center, we have very expert radiologists in interpretation of child MRI and children MRI, and also we have a good facilities for doing MRI and with good view and good images. So we decided to do the MRI again. And after that, that was the report of the second MRI. So with this aspiration that was completely bloody, and then the result of the MRI, it was obvious for us that it is not a JIA or simple synovitis. We can say that was a pigmented bilionodular synovitis. So after that, our orthopedic colleagues helped us and do the surgery and did the surgery. So that was for the second patient that we had the problem for the diagnosis, and that was good for us because we do not see any very PVNS patients, because it's not very common between the children for having PVNS. And that was a good experience for us. Always think about other reasons of joint swelling instead of just thinking about JIA.
Yeah, no, those are really good cases, and we have only had one PVNS here, so I agree with you. It is rare, but thankfully it's kind of stuck in my head. We've had two other in the last couple of years, two other mimics of JIA presenting as a monoarthropathy. One in an elbow, so a big swollen restricted elbow, which we initially treated as oligoarticular JIA, but which didn't respond in the way that we would expect to joint injection and eventually methotrexate. And actually he turned out to have an osteoid osteoma, which of course was picked up only on CT scan, which we wouldn't routinely do. But obviously when he didn't respond as we expected, we then had to think again and look again. And we had another child with a big knee, who again came to us having had a knee injection, but then turned out to have a huge vascular anomaly. It was a sort of AV malformation type thing. That one, when we did an ultrasound scan in clinic, looked very odd. It didn't look like the typical appearances of JIA, and there was much more Doppler because it was so vascular. But yeah, these are very interesting cases, and they help to remind us to always. And I think usually it's when the treatment response is not as we expect that we then go back and think again. And TB and celiac disease are the other ones that sometimes catch us out, I think.
You know, the interesting part of the history of the second patient was that his brother said that they did aspiration in another city, and the joint was normal after the aspiration, but immediately the day after the aspiration, the swelling came back, and the knee was the same again. So that was interesting part of the history that we have to pay attention more to this part of the history, that this is not a simple JIA, because when you do aspiration, you don't see that the joint swelling came back immediately after that, the day after the aspiration. So this is the good and interesting point of the history, that every doctor have to pay attention to every detail of the history, and could help to diagnose better for the patient.
Excuse me.
Okay.
Can I speak about the ultrasound? Surely, ultrasound is the first choice for evaluation of the knee. And in PVNS, we can see joint effusion that have a debris, and we can't difference between septic arthritis or hemorrhage. And you can see in ultrasound proliferation of Synovium, and maybe it's been hyperemic or not. If it be hyperemic, okay, we say it may be JIA, but if it's not hyperemic, maybe another diagnosis should be considered. And after see the joint effusion with debris, we say that to do tapping. About the MRI, I should say, because in Iran, MRI is cheap, and in this center, it's accessible for every patient. We do very soon MRI.
Sometimes it is the first choice for doing an imaging. And this is the benefit of the third world country, that you can do very expensive things with a very cheap amount of the money. So this is the benefit of our country. So let me ask a question from Dr. Zamani. Dr. Zamani is our radiologist in our centers, and we get help from her and her colleagues very much. You talk about the hyperemia of the synovium. Do we have this kind of hyperemia in PVNS also, or we don't have any hyperemia of the synovium? Is there any is there any differentiation between the hyperemia of the JIA synovitis or pigmented villonodular synovitis?
Hyperemia in JIA, it's more likely and more common.
Okay.
In PVNL, maybe we have hyperemia, but the profession of PVNL is villonodular, and it's fraud-like the synovium. But in JIA, the synovium is thick. All of the synovium is thick, not nodular or mass-like, focal mass-like lesion in the synovium. And mostly, if it's active, we have panus and hyperemia more common than the PVNL.
The difference that I noted on ultrasound between this child we had with PVNS and JIA was that so normally we would expect to see thickened synovium when we scan in JIA. plus effusion, plus minus hyperemia in a knee. But the synovium in this kid with PVN, who turned out to have PVNS, was so much more proliferative. I'd never seen anything like it. It was so thick. It filled the whole cavity, and it very different from what we would normally see on ultrasound in JIA. So that was the clue that this wasn't.
Yes, it's a mass-like in the PVNS.
You know, Dr. Zamani, Dr. Lehi is an expert in musculoskeletal ultrasonography, and this is her interested field. So she has very good view about the ultrasonography of musculoskeletal system. So that was very good to have her idea about this kind of procedure in this patient. And this is
Yes,
the
of
reason
course.
that she insisted on doing ultrasonography of musculoskeletal system, because I know that we can get good information and very valuable information by doing ultrasonography of musculoskeletal when you are an expert of this field. Because I know that this field needs some kind of more knowledge other than just radiology. We have to consider many conditions and then doing ultrasonography. So thank you, Dr. Lehi, for sharing your experience in these conditions. Okay, any other question?
No, those are excellent cases. Now we'll go away and if you can send me the slides, Dr.
Okay,
Synovium,
okay.
we'll go away and have a think about the first case, because it's clearly something weird,
Yes.
weird and wonderful, isn't it? Or a strange presentation of something common, or I don't know, but I'll have a think about that. Thank you very much to all your
Okay.
presenters.
I
Thank
do
you
it
very
as
much.
soon as possible. Thank you all attendees, and thank you. Sorry, your microphone is on. Okay. Okay, thank
Sorry
you.
to join late. But I was going to say, if you could send the slides as well, that would be great.
Sorry, I think Dr. Genovese is talking. Yes or not? Which one of the attendees is talking? Okay, let me thank all the attendees and all of my colleagues, Dr. Panjabi, our orthopedic expert in our center, and also Dr. Zamani, our radiologist, to attend in this meeting and say hello and thank Dr. Fatima Jenabi. You know, she belongs to us and now working with you. So, as you said, she is the bridge between you and me.
We've
So-
stolen her. We've stolen her from you.
Yes, yes, yes. And thank our fellows, our colleagues, Dr. Movahedi to present to case. She is a good fellow in our center, and I must thank her. And see you next time. And I hope to see you very soon. Not as like as this one, because that was summer and all of us was in summertime and hobby time and just rest time for the summer. So I hope to see you very soon again. Okay, if there's no question, goodbye. See you till next meeting. Thank you so much.